This is Dr. Robert Berry. This segment is about sciatica, also known as lumbar radiculopathy. Sciatica is the pain that follows the path of the sciatic nerve, which is basically, it comes out of the buttock, down the back side of the leg, typically down the back, all the way down, sometimes into the foot. It's highly variable. You can go into both buttocks if you've got bilateral pinching on both sides. It can go down just one. It can present itself as weakness and numbness without the pain. But mostly you're going to get pretty severe pain, especially if you did it abruptly, like with a big lift or getting up from a sitting position and all of a sudden you have this horrific pain down your legs. This is typically, the acute part, is typically caused by a ruptured or herniated disc. You know, for all of us, they're basically the same term. Everybody asks about that, but ruptured disc is the same as a herniated disc and close to a protruding disc. I'll kind of go through that later, but basically, it's in the wrong place, pinching the nerve, giving you pain. Like I said, both sides, sometimes with numbness, tingling, and weakness, it is variable. Causes, as mentioned before, is typically from a ruptured disc. It can also come from spinal stenosis. Spinal stenosis, by definition, is a narrowing of the tunnel or the canal that the nerves go through, either the spinal cord, the nerves below the spinal cord, or out into what's called the neuroforamina. It's just narrowed. The nerves traveled in these very defined paths. The disc, to give us our flexibility in our spine, sit right in front of that nerve, and in back is a bony roof that covers it, and that's where the severe pinching is. So we have herniated disc, we have spinal stenosis, which are bony spurs, typically in an older population, because it takes a while to develop that. We also have a combination of both of those, which I see frequently. Also this condition called spondylolisthesis. This is an instability of the spine. Sometimes develops very early in life, sometimes it's a part of trauma. What's the most often cases we see? It's typically in 60 to 65-year-old females more than males. They have a slight structural deficiency around the pelvis that allows that, typically at 4 or 5 level, to go forward like that. When it goes forward, it doesn't cause that much pain, believe it or not, because it happens very slowly, but eventually pinches the nerve. So I have patients that say, I used to be able to walk a mile or 2 miles, and now I can't go around the block with starting to get pain and discomfort in the buttocks and down the legs. Another syndrome is called piriformis syndrome. This also can give you sciatica because the nerve travels through a muscle type area that can get quite dense, and that's typically pinched. That usually responds to physical therapy. Trauma, I kind of mentioned before, you obviously can get it being in an accident, having a severe accident, fracture dislocation, or an auto accident where you're just bending forward and get the same type of effect. Risk factors are kind of head up for prevention, so that's the way we kind of look at it. This condition, sciatica or herniated disc, does run in families. I'll see patients, they said, oh yeah, my brother had that, my father had it. It's probably a genetic predisposition that comes from having a gene that just predisposes us to an earlier deterioration in the disc, making it more likely to rupture or come out of place from the stress that we're putting on it. Also, almost anybody that's had a previous injury, not with a ruptured disc, but they kind of hurt their back, maybe a small disc bulge that never really healed itself up. Then when it happens again, the wall that holds the disc in is so weak, it just rips apart and the disc comes out always under pressure. So previous injury is a prelude to that. Obesity, clearly, if we're bigger than we feel like we should be, we're putting a little bit more pressure on the disc and on the whole vertebral structure. So it behooves us to try to find what is a good weight for us. Weak core, believe it or not, the core takes more pressure off the spine than back, where back exercises. So I'm always pushing core. For those who have, I really don't like sit-ups and I don't like the rowing, especially the rowing where it causes a big flexion moment. So I really like the crunches. You can look them up where you just kind of lay it down and you're coming up part way and you're just tightening that stomach. I promise you, if you build up the core, you're going to decrease your back pain and the incidence of injury. Inactivity. Inactivity is a risk factor for almost all of us for a variety of diseases, but the spine, I don't know, we just kind of get in that posture where we just kind of slump and we lose our abdominal musculature and we're just not up to our fit self. So the unfit will have an increased incidence of back problems. Dehydration. 80 to 85% of our discs are full of water. So if we're in a chronic dehydrated state where we're just not getting enough fluid, the disc will feel it too, just like cartilage in our knees and earlier osteoarthritis. So I would really push for regular hydration, and you can kind of go online and get a feel for what the regular hydration is for you, or call your healthcare professional. Occupational causes, clearly some people are in a position where they are more susceptible to spine injury. Hod carriers, bricklayers, typically construction trades, the truck driving trades, anywhere where you're doing repetitive lifting, twisting, or bending, you're going to have a higher incidence of injury. Poor posture, that's an obvious one. If we're bent over kind of like I was, like that, you put a little bit more pressure on the disc, it kind of frays the wall or the circle that holds the soft disc in, and that can break down over time. So watch your posture, don't sit or stand too long, get up and walk around. Obviously, degenerative disc disease and osteoarthritis both play a role here. Diagnostics. A full workup for those who have serious spine problems, and you know what I mean. I can't go into every condition here because we just don't have time. But serious spine problem, not getting any better, a lot of pain, neurological changes that just aren't acceptable. You need to see a qualified healthcare professional. That's just the way to go. That's the way to get the diagnostics and treatment. The doctor's office is typically going to order regular x-rays to see whether you have any instability, any deformity, fracture, any obvious cause for what's going on. They may do blood work, looking for a disease causing this. They may do nerve conduction studies to see which nerves are involved. But the biggie, of course, for all of us is the unbelievable accuracy of modern MRIs. They really are magnificent. They make it very easy for the physician to determine the best course of treatment for you, and really easy for you to understand once you look at the MRI and you're given an explanation. I'll give you the good news here first. At least 60% of the patients with sciatica, even from a ruptured disc, especially strain, sprain, injury to the nerve, about 60%, somewhere in that range, tend to get better over time. What's that time? 3, 6 weeks, 3 months. You can get better, but you have to be showing improvement of that. Otherwise, you're not going to like it. Your doctor's not going to like it. Self-care, reduce your activity, get rest, watch the lifting, twisting, and bending. We're trying to get the swelling go down. We're trying to get the pressure off of it. Those are some that none of this stuff is going to work. You're going to have severe leg pain. You're going to have neurological deficit. These require a more urgent approach. But for those of us who have the mild symptoms in the beginning, nobody wants to rush off to see the doctor unless they're one of those other patients that we're talking about. If they've had sciatic before, or they just kind of feel a little pain in the back, a little down into the leg, and no neurological deficit, no numbness, tingling, no weakness. Observation is fine. That's rest. That's taking it easy. That's taking acetaminophen. It's taking non-steroidal anti-inflammatories if you're cleared by your doctor to take that and you don't have heart disease, kidney disease, or especially stomach disease, since it tends to erode the lining of the stomach. I also like ice and heat packs. Sometimes the icy hot stuff is very, very effective. Sometimes the heating pad, sometimes the cold pad. Everybody's a little bit different. Time. What is a reasonable time? We like people to get better in 3 to 6 weeks. We like them to be going the right way. I mean, it might be like this, where they've got a little step back and they're going well, and then drops back a little bit because they do too much. But in general, the trend is from left lower to right upper, where on their own they're getting better. If during that course you're one of those people who can't take the regular medications because of those conditions, see your physician and see who's got something, he or she has something that can work better for you and doesn't cause those complications. Eventually, you're going to see the physician. The things that they order are pretty appropriate. Sometimes it is just a shot in the butt of steroids, and sometimes Toradol, which is a very strong anti-inflammatory. Sometimes it's referral to a physical therapist, sometimes an occupational therapist that can talk to you about all the wrong things that you're doing. Sometimes it's an epidural shot, which is basically taking the same steroid and putting it in the midline of the back, and it kind of spreads around that area. Sometimes if it's just severe nerve pain, a specialist will do a selective nerve root block, where he's taking a needle and very carefully putting it down close to the nerve, and then we'll squirt the steroid, maybe Toradol, in there. We're trying to settle that nerve down. What's kind of exciting is we're in a mode where there's a lot of money dedicated to it and a lot of research in stem cells and stem cell variants, kind of products that come off stem cells. It's my belief that someday, hopefully, specialists will be able to inject stem cells by your nerve, and not only will it take the swelling down, but it'll help it heal itself. But that's a ways down the road. It's still in research mode, but that's something you might want to keep your eye on. Surgery, as mentioned before, most people get better on their own. Natural healing, physical therapy, medications, and just kind of the slow improvement over time. And then changing their activities can be very helpful. But there's just a group of individuals where things just don't get better. My particular case, when I ended up surgery in my neck, because you can get the same thing in the neck where the disc ruptures here and it goes down your arm, it was just intolerable. I had neurological deficit. I'm a surgeon. I can't have numb hands. And I had to have it done pretty quick. But for most of us who have the milder symptoms, we can kind of wait it out and see a professional and see what they have to say. The indications for surgery, lumbar spine, herniated disc, are I'm just not getting any better with conventional treatment. I'm frustrated. I have the pain all the time. I've done everything that you asked me to do. I've done the medications, rest, injections, maybe even 2 or 3 injections, and I can't live like this. Fortunately, the surgical treatment for most ruptured discs, herniated discs, where it's just the disc, is a microdiscectomy. This is the most common procedure done, and I'll talk about other procedures down the road. But a microdiscectomy, you can look it up. This is done hundreds of thousands of them. Very small incision, typically about 1 inch for most people, sometimes longer if the patient's a little bit bigger. It's really not the important thing. The important thing is your pain relieved? But everybody's worried about this, the length of the incision. I think it's correlated to recovery. And I do try to keep it very, very small. And then go down. We never cut the muscle, but we sometimes have to strip the muscle off the bone, retract it out like that. Then we'll take what's called a characterized, which is just a very cool little punch. And I'm taking this minimal amount of bone. The bone covers the nerve, and so you have to remove this lamina that sits over. It's kind of the roof. It's usually about that wide, typically about that long. If there's any spurs in there, you want to remove that lamina enough to safely see the nerve. Then you gently retract the nerve with special retractors. You're just pulling it over a little bit. And then there's the device called a pituitary, and you're going down and you're just pulling this disc out until you're happy. You try to remove everything that's pinching the nerve off, and you also try to prevent any rupture in the future by going down to the disc and seeing if you can feel any disc that might rupture in the future. This typically takes less than an hour or so. The closure is very simple. You have a nice little dressing. And I'll talk about the post-op in a minute. More serious stuff, like I talked about, the urgent stuff is I really do have numbness, tingling, and weakness. I'm really having trouble walking. It really is not getting any better. Or the pain is just insufferable. I can't do anything with my family. I can't go to work. So I'm going to say severe pain, neurological deficit, severe radicular pain down the leg. That's a more urgent condition. That needs to be moved up. That's what I always did in my practice, is I moved them up as soon as I could to try to get relief for them. Urgent, super urgent, go to the emergency room, is a condition that's not very common, but you will hear about it. It's called cauda equina. It's called cauda equina because cauda is tail and equina is horse. If you look at a horse tail, lower than, say, T12 or 11, T12 or L1, the spinal cord ends and it goes into a big mass of nerves that looks like a horsetail, and each one of them separate and go out through these tunnels all the way along. So that's called cauda equina. Cauda equina syndrome is you've got something so nasty, you fractured, or you have a huge massive disc, or you have severe stenosis, and it's pinching everything. That is an emergency. You get your butt to see somebody, see some professional right away, or you go to the emergency room. And that will be sometimes loss of bowel and bladder. That's an emergency. Go to the emergency room. Severe pain down both legs, sometimes accompanied with that. You'll know it when you get it. And what I'm saying is that's an emergency. The rest is usually optional, and we can do it when it's best for you and best for surgery. I just want to briefly mention the other procedures that are much less common. Sometimes, as I mentioned before, this is spurs coming on and just pinching the nerves. And sometimes that's just what's called a laminectomy. And the disc is really not a huge part of it, but the pressure on the nerve is causing kind of classic sciatica. And what it is just slowly nibbling at the bone of that roof that covers the nerves, and they're compress down like this, and then when you decompress it, you've taken all that bone off. They're coming back into a more comfortable state. That's called the laminectomy. Sometimes outpatient, sometimes a day or two in the hospital, sometimes one level, sometimes multiple levels. If it's a little bit bigger, you might be staying for a little while. And then I will let your physician talk to you about benefits, alternatives, and risks. That is not in the purview of this discussion. The last one would be sometimes we have to do a decompression or discectomy, and we have to add a fusion. That is in people who have spondylolisthesis, which is a slip, which we talked about, because if you go in there and take some of that lamin, it might be unstable, or you might have a lot of back pain to it. It just has to be stabilized. There are also several patients that just have the ruptured disc, but they have severe back pain with that. Then I'll talk to the patient about it and see, I can take your disc out, and that's going to help the leg pain, but not so much the back pain, because it's still a bad disc. You ruptured out of a bad disc. And we don't have any magic formula yet, stem cells or anything that we can put in to build that disc back up. And so for those that have the special conditions, sometimes fusion is considered. That's typically through the back. And then one thing I want to mention, before I get to that, typically the success rate for these procedures is pretty high compared to other surgeries. And I look in the literature and they'll quote anything from 78% up to 90%. But I got to let your surgeon talk to you about that. That's really not my purview. I've had some patients ask me about lumbar disc replacement. And I think that lumbar disc replacements can be helpful in certain situations, especially though for back pain. But when you have something in the back that's pinching the nerve root, you're really not going to effectively get that. You can replace the disc, but you can't always get the pressure off the nerve that you really want to get. So I'm going to say, don't think of disc replacement when you have mostly sciatica and mostly leg pain. It just won't work as well as having it done in a more traditional way with the microdiscectomy. If you have the surgery, like I mentioned, the most typical surgery by far is an outpatient microdiscectomy. As I mentioned, a small incision, very little bone removed. And so we try to keep your structural integrity. We take the pressure off the nerve root, which is always the most important part. In a typical case, you will be up and walking the same day. You will be eating that same day and go home that same day, or possibly an overnight stay if there's a lot of pain or other things that require stay. You typically can go home in a car and with somebody taking you and making sure that you get into the house. And that's a matter of what your doctor says you can do at home. Activities are dictated not by me, but by your physician. But I'll tell you, in general, most people are back to work. If it's kind of light work, clerical type stuff, computer stuff, sales, light sales, where they're not getting into their trunk and things like that, they're back kind of part-time in a week or so, then kind of full at 2 to 3 weeks. If you're big-time laborer, hod carrier, lifting bricks, construction, you know what I'm talking about, you can take quite a bit longer for it. And that, again, is up to your practitioner. So that's it. I hope it was very, very helpful to you, and I appreciate your time.